as F&E. Okay? It is a foundation so that then when you start to look at all of our other disorders, a lot of it goes back to F&E and renal. Okay? When we talk about neuro and musculoskeletal, pull back fluid and electrolyte, because a lot of our neuromuscular disorders have to do with electrolyte imbalances. Okay? It's not all trauma and stroke. Okay? Or spinal cord injury. Okay? Bailey, will you hit the lights? Okay, don't fall asleep on me. So we're going to start with assessment. Okay, and the primary thing that we talk about with renal, the job of the kidneys is what? Elimination. Okay, then we pull in two priority concepts: fluid and electrolyte balance and acid-base balance. Okay, that's why we had F&E and acid-base to start out with. Okay, there is a method to the madness of our curriculum. Okay? So when we look at fluid and electrolyte balance and acid-base balances, okay, we look at our structures. Okay, now first thing we notice is we've got two kidneys. Can we function without one kidney?
Yes.
Yes, we can. Okay. Can we function without any kidney function? Not for a very long period of time, because then this thing called dialysis is required, right? Okay, but dialysis, okay, is kind of a temporary fix to something that's terminal. Okay? The structure of the kidneys, okay, look over your A and P, right? The functional unit of the kidney is the nephron. Okay? Why do we find it important for you to understand the nephron and especially the juxtaglomerular complex? Why? What's important about the juxtaglomerular complex? Why is it important when we talk renal? Anybody know?
Blood flow to the kidney?
Well, blood flow to the kidney, but specifically what happens when we have decreased blood flow to the kidney? What happens? Yes, the renin system gets kicked in. Okay? So if we look right here, renin-producing granular cells. This is important because this is where renin forms. Okay? You must know that any time there is a sensing of decreased blood flow to the kidney, the Renin-Angiotensin System gets activated. So any condition that would cause those sensors to go off, we've got low blood flow, renin's going to get secreted. Is that trauma? Is that obstruction? Whatever that cause is, renin gets formed. Then what happens to your blood pressure? Goes up. Goes up. Okay? So our cue could be decreased urinary output, but an increase in their blood pressure. Okay? So the renin tubules, okay, what's their job? What? Reabsorption, okay? When we talk about application, okay, this was an example, okay? If I just said, what's produced here, okay? But we took it a step farther to say application of this content is that we know anytime there is decreased blood flow, renin gets stimulated. Okay, that's taking it to application. Okay? Let's take our knowledge of the renal tubules to application. What kind of medications? Diuretics. Okay? So it's important to know, kind of have an idea of if my patient's on a loop diuretic, where's that affecting? The loop of Henle. Okay? An osmotic diuretic. Where do you think that works? Anybody got a guess? Proximal. Okay, thiazides in the early distal. And then our late distal are potassium sparing. Okay, so that's taking it to another level of understanding. So when we talk about you having a basic understanding of anatomy and physiology, it's not just what are the structures of the renal system. Okay? It's what are the structures of the renal system and how do they affect me providing care to my patient. Okay, what do I need to understand? I need to understand how those meds are going to work. I need to understand that if my patient has had significant blood loss, okay, that I should expect decreased urine output and maybe an elevated blood pressure. Okay? So now we're going to look at kidney changes associated with aging. Okay? When we look at each body system, we're going to always talk about what happens as the body ages. Okay? Now, you're going to have an entire course on geriatrics. Okay? But that's not going to break down every body system for us. Okay? So it's really important that we understand some things that happen. Okay? We start to see some tissue loss. The nephrons get smaller. We have blood flow to the kidney that declines. So what do we automatically think? If blood flow starts to decline, elevated blood pressure, renin's getting secreted. Okay? Their glomerular filtration rates go down. They start to experience nocturia. What's that? Loud. Who had it?
Nighttime urination.
Nighttime urination. Yeah. Okay. And we talk about that when we talk about musculoskeletal because what happens? Elderly people get up in the dark to go to the bathroom and they trip and they fall and they break something. Okay? Or they hit their head and they have a bleed. Decreased bladder capacity, weakened urinary sphincters and shortened urethras in women, and then a tendency to retain urine. Okay? So, what is this tendency to retain urine? What's the term for that called? Yeah, urinary retention. Okay? It's not something that we want to happen because anytime we have stagnant urine, bacteria can develop. Okay? So that's why we worry in our elderly population about UTIs, urinary tract infections. Okay? Because they may have a tendency to retain the urine and get an infection. So our assessment, recognizing the cues. Okay? Our history. We want to know demographic information. What are demographics? What are demographics?
Where they're from, culture.
Mm-hmm. Kind of the who, what, when, and where. Okay? Why is that important? Why are demographics important?
Different nutritional lifestyles.
Okay.
Just lifestyles in general.
Lifestyles in general. Okay. What else? What are some other important things about demographics?
Like to know what you're looking for in a specific person. For a child, you would be looking for something different than an older adult.
Okay. Yeah, because are kids going to be as forthright with information maybe? Or even young adults? Young women? experiencing renal difficulties, urinary difficulties?
Like the different risk factors that they may have, whether ethnicity or
So, different risk factors. What else? Something I think we take a lot for granted.
Or hygiene, like your toilets that has running water.
Toilets, running water. Yes. Okay. The ability to cleanse. Okay, we had a toilet paper shortage during COVID, right? Okay. What else?
What education?
Education. Okay. And that kind of ties into understanding the patient's level of knowledge and their understanding. Okay. Because that patient could have a lot of fear. They could have anxiety. They could be embarrassed. Okay. We want to know what their voiding patterns are. Okay. And when we say voiding patterns, you and I know what that means. But if we say that to a patient, are they going to know what that means? Okay, so what do we have to say? How often do you pee? Yeah. How often do you urinate? Because sometimes patients don't even know what urination means. Okay, so we have to make sure that they're understanding the language that we're using. Okay. And it's not necessarily a cultural language barrier. It's because we're talking in medical terminology and they don't understand it. Okay? What else for demographics? Do you think of anything? What about just their access to health care? And you know, we have 2 hospitals locally. We have abundance of physicians, but that's not necessarily the case all across the United States. A lot of people don't have insurance. I have to tell you, I grew up in a household where my dad was self-employed. Okay, one of my big goals, okay, I couldn't wait till I had a job where I had insurance. Okay, that was a big deal. Okay, now it's standard, isn't it? Everybody just assumes, oh, I'm going to get a job and I'll have insurance. But I'll tell you, as a kid growing up, we didn't go to the doctor unless we had something severed off, the bone sticking out, or we were almost dead. Okay, because we paid out of pocket. Okay. Yeah. Okay, can you imagine that? But there are still people that, I mean, even with COVID, we're seeing patients who have delayed care because they were afraid to go to the hospital. Okay? So that socioeconomic status plays into nutrition, access to health care. Nutrition is a huge one. Hygiene. Okay? We take for granted that we're going to have running water, hot water, that we can afford soap for hygiene. Okay, that's not always the case. We want to know their medication history. Why is medication important?
Some medications can cause you to use the restroom more or cause urinary retention.
Okay, so some medications can cause urinary retention, cause you to go more. Okay, some medications that we give patients are actually toxic to the kidneys. Okay, they can cause permanent damage. Okay, and those are called nephrotoxic drugs. Nephro meaning kidney, toxic, dangerous, deadly, nephrotoxic. Can anybody think of a medication that we might give patients that's nephrotoxic? NSAIDs? What else? Here's a big one.
It's vancomycin.
Vancomycin. Okay. And we give it a lot in the hospital, don't we? Okay, it's one of our big gun antibiotics. But it can also cause permanent damage to the kidneys and cause our kidneys to malfunction. Okay. There's a list posted on Canvas for you. Make sure that you're aware of nephrotoxic drugs. Okay? So the family history and genetic history, because sometimes we have genetic anomalies. Some disorders that we're going to talk about are genetically related. Polycystic kidney disease. Okay, and then we want to know their current health problems. What's their nutritional status? Okay, are they having pain? Are they allergic to anything? Okay. Have they recently been treated with new medication or had an infection where they received antibiotics? Those sorts of things. And then we're going to do our physical assessment. We want to look at their general appearance. What's their skin look like? Why would we want to look at their skin if they have renal disease? Okay, so turgor, hydration. Think about acid-base imbalance. What do we talk about? What can happen? Okay, so when those toxins build up, when we get all those nitrogen waste, okay, the kidneys aren't getting rid of them, so they have to come out of the body somehow. Okay, and they come out through uremic frost. Okay, that white flaky stuff on the skin. Okay. My skin gets real frail, thin, starts to flake off, it's dry. I bruise easily. We want to ask them about their kidneys, ureters, and bladder. Now, how are we going to assess those? How are we going to assess those?
Urine output.
Urine output. What's the urine look like? How much? How often? Does it smell? Are there any tests that we could do? BUN and creatinine. Okay. We can also do an x-ray called a KUB and upright. Kidney, ureter, bladder. KUB. Okay, so that's a quick, non-invasive. Okay, we don't have to stick anything in them to take the x-ray. Okay, the urethra. Okay, now as a nurse, we probably won't examine that, but the physician will. Okay, is it red? Is it swollen? Okay, does the patient report drainage and discharge? And then psychosocial. Okay, again, that fear, that anxiety. What's the patient's level of understanding and knowledge? Okay, so here's our lab test and then our imaging. Okay, so our blood test we already talked about. Okay, we said what? BUN and creat, right? Okay, is there anything else? There's this thing called a BUN-creat ratio. Okay. We also look at our glomerular filtration rates. Okay, and if you look on page 1313, it gives you the serum creat, BUN, and the BUN-creat ratio normal findings. Okay, so for testing, those will be the numbers that we go by for normal values. Okay. Then we look at blood tests or urine test. Okay. One of the things that you need to keep in mind is that there are certain things in urine that aren't supposed to be there. Okay. Anybody know what those are? Protein. Okay, what else?
Glucose or sugar?
Protein, glucose. What else? Blood. Okay. So blood, protein, glucose, nitrates, WBCs, okay, pus are not normal things to see in urine. Okay, so if we see those, okay, we automatically think something is wrong. Okay? I'm going to add one more thing. What does that tell us? What do ketones tell us?
They're in acidosis.
Okay, that we've got an acid-base imbalance going on. Okay, our ketones. Now, how do we know if these things are present in urine? A urinalysis, okay, or a urine dipstick. Okay, you guys know what I'm talking about when I say urine dipstick? Okay, we get a urine sample, we have the little, what? The strips. Okay. You either dip it or drop the urine on it. You wait the designated amount of time, and then you compare it to the label on the bottle. Okay. That's kind of a rapid. Okay. For a hospital urinalysis, okay, that gets sent to the lab. Okay. They run it. And a lot of times you'll see a urine with C and S. Okay. Or C plus S. Okay, the C and S, or C plus S, is culture and sensitivity. So that if they do have an infection, or what we think, okay, nitrates, WBC, maybe some blood, we think, oh, maybe they have a UTI or an infection. We're going to culture it so that we can then see what kind of bacteria grows, so we can get them on the proper antibiotic. Okay? Then when we look at the x-ray type things. Okay, first thing there is KUB. I mentioned that already. CAT scans and MRIs. Why would we want to do those? What kind of condition might tell us information on a CAT scan?
There's an obstruction.
Okay, so obstruction, okay,
Stone.
maybe. What else about obstruction? What other things can cause obstructions? If they're growing.
Tumors.
Tumors. Okay. Ultrasounds. Okay, we can look at function, renal scans, renal arteriography, okay, making sure that we have good blood flow. And then we have another set of diagnostics where with a cystoscope or a cystourethroskop, okay, they're using a scope, a camera, going in, looking at the urethra, looking at the bladder for abnormal tissue or blockage or damage. Okay? The cystograph or the cystourethograph, Okay, that's where they'll inject dye and then do an x-ray, an image to see, is there blockage? What's happening? That's kind of the same way with the retrograde procedures. Okay, like with some of them will insert IV dye, and then they watch to see how that dye is then filtered through the bladder and through the kidneys. Okay, looking for stones, obstructions, leaks. Okay. But it gives us a good picture of the ureters and the kidney. We have urodynamic studies that look at the pressure, how much volume. And then a kidney biopsy is actually taking a sample of that tissue to examine for abnormalities, specifically cancer. I'm going to back up to the urine test. Okay. Look on page 1314. And one of the things, it's 1, 2, 3, it's the fourth thing down. Specific gravity. Okay, specific gravity should be 1.005 to 1.030. Okay. One thing that you should kind of keep in mind, okay, if you have a patient who is dehydrated, they have an elevated urine-specific gravity. Okay. If they have kind of fluid overload, they have been overhydrated, their urine-specific gravity will be low. Okay. And there's this unusual phenomenon called a fixed urine-specific gravity that we can often see in patients who have end-stage renal disease, where their urine-specific gravity, no matter what their hydration status is 1.010. They could be severely dehydrated, but it's still 1.010. We could bolus them with fluids, and they will be 1.010. Okay? So make sure that you know the urine-specific gravity. And that's a quick telltale sign of what's my fluid hydration status for my patient. Are they dehydrated? Are they normally hydrated? Okay. Or have we recently bolused them with a lot of fluid? Okay. All right, questions that you have. Let me look through my notes. I went through that really fast. When you are assessing a patient, okay, I talked about a lot of times they will have dye, an IVP. They'll have dye. What allergy do we need to assess for them? Shellfish, iodine allergies. Okay, so make sure that you're aware of that. Okay? All right. Any questions before we move on to chapter 61? Stress incontinence, I think, is our first. Okay, so moving to the next chapter, we see our concept stays the same. It's elimination. Okay. But we've got completely different interrelated concepts. Okay. Number one, we've got pain, immunity, and tissue integrity. Now, one of the first things we're going to talk about is urinary incontinence. Okay. Will our patients have pain with urinary incontinence? Yes or no? What do you think? No. Usually no. Okay. But will they have immunity or skin integrity problems? Yeah. Okay, they can, because with urinary incontinence, they are at risk of developing a urinary tract infection. Okay. And we have basically 4 types of incontinence that we're going to talk about. Okay, now there are other, if you go and specialize in incontinence, there's going to be subtypes. Okay, and this number almost quadruples. But for our purposes, okay, we're going to talk about 4. Okay. Incontinence is the involuntary loss, okay, to control your urine function. Okay. So that could be because of a type called stress incontinence. Okay. What do you think that's caused from?
Stress.
Well, it's called stress, but it's actually related to pressure. Okay? So if you think of stress in relation to pressure buildup, okay, and that pressure is typically things that increase our intrathoracic pressure that then puts pressure on the bladder. So when I cough, when I laugh, when I sneeze, I leak urine. Okay? So it's an involuntary loss of urine control related to pressure. And examples are when I laugh, when I cough, when I sneeze. Okay. If I strain. Then we have urge incontinence. What do you think that's from? What's the name tell you?
They have the urge to go.
Yeah, I have this constant urge to go. They can't combat this urge to go. They can't suppress the urge for urination. Then we have overflow. Okay, and I'd love to do a study on nurses because we probably, as a nurse, have these. Okay, what do you think it's from?
Holding it too long.
Yeah, over distension. Okay, so we have only a certain amount of volume that our bladders can hold. Okay, what's that normal volume? Anybody know?
15 retreat.
Loud?
15 retreat.
Well, when should we get the urge to go? Anybody know? When we have about 120 in our bladder. Okay, so that when it has 300 to 500, we should be emptying our bladder. Okay, because our bladder capacity should really only be about 300 to 500. And then we need to go to the bathroom. Okay, so when we have those patients that we take to the bathroom and they void 600, 650, 750, what's that tell us? What's that tell us about their bladder? It's distended. Okay? And when we hold, it's just like a balloon. Okay? We blow that balloon up, we let it go. We blow it up, we let it go. And then what happens to it eventually? It just keeps stretching, doesn't it? Okay, that's kind of the same thing that's happening with our bladder with overflow. Okay, it loses its ability to contract like it should, and it just keeps expanding. Okay, and then that puts us at risk for what? Urinary incontinence, urinary retention, because we're losing that muscle structure. Okay? So then, the last one there is called functional incontinence. What do you think that's caused from? Who do we see that in?
I said elderly.
Elderly? Why?
Because the kidneys don't function well.
Close. Kidneys don't function properly, but functionally what happens? Okay, so can't get up and go. But what else? Dementia. Okay, I forget. Okay, so that's why it's so important when we say our elders need to be on a bladder program. That's to promote good urinary and renal health. Okay, quite honestly, it's good for everybody. Okay, everybody should be going to the bathroom at least every 2 hours. Okay, that prevents this overdistension. Okay, it prevents stagnant urine, promotes renal health. Okay, but dementia. Okay, functional. Something that prohibits them from being able to go. So maybe I have fractured my hip, okay, and I can't get to the bathroom. Okay, there's a functionality there. Okay, with maybe Parkinson's disease. Okay, other forms of dementia, Alzheimer's. Okay, those types of things. Okay, so now we're going to look at some different causes. Anytime you see the word etiology, okay, that means cause. Okay? Surgery. How could surgery be a cause?
Don't we give them, I can't remember the type of medicine, but to dry them up?
Okay, so medications. Anesthesia, yeah, just anesthesia is going to kind of disrupt your neural pathways, if you will. Okay, as will a spinal cord injury. Okay, we'll talk about it later, but the innervation of S2 to S4, okay, innervates your bladder and your bowels. Okay, and if I have a spinal cord injury there, okay, I may lose the ability to control my bowel and bladder. Brain and nervous system disorders, because of that neural pathway disruption. Head injury, stroke patients, trauma patients, patients who experience MS, Lou Gehrig's disease, chronic back pain. Okay, depending on, I may have a ruptured or herniated disc that is compressing on my spinal cord. Different disease treatments. So methods to fix one problem I have may cause urinary incontinence because of the treatment program that I'm on. Okay. And a lot of those drugs are used to treat behavioral health issues. Antidepressants and antipsychotics. Okay. Our calcium channel blockers can cause incontinence. Okay, there's a nice table on 1328. Okay, it lists some drugs. Okay, central nervous system depressants, opioid analgesics, diuretics, drugs that can contribute to changes in mental status. Okay, antidepressants, antipsychotics, anticholinergics, depression, diseases, stroke, Parkinson's, dementia. Okay, all because those affect the functionality of the patient. Okay, depending on where that injury is or that impairment in the brain. Okay, and then factors associated with aging. What happens? Maybe I get rheumatoid arthritis and I can't move. I can't get to the bathroom fast enough. And I become incontinent. As many as 45% of women over the age of 65 report incontinence. Okay, that's nearly half the population. Okay, and a key word here is report. Okay, we truly believe that number is much, much higher. It's just underreported because of embarrassment. We have increased risk with chronic conditions, heart disease, depression, okay, vaginal deliveries, pelvic prolapse, prostate problems. Okay, so yes, it's common in women, but men can become incontinent as well. Patients with diabetes, heart failure, and obesity. Okay, one of the things that physicians are really encouraging, okay, lose weight. Okay, to have less, most patients have a huge abdominal girth. That weight just adds extra pressure onto the bladder. Recognizing cues, history. When we go to ask the patients, okay, about their urinary history, okay, we have to be very detailed and structured in the questions that we're asking them. Okay. Do you dribble? Do you have a hard time starting your flow? Okay. About how many times a day do you go to the bathroom? Okay. Do you have the urge to go and then you get to the bathroom and you can't go? Do you have to go at night? If so, how many times? When you go to the bathroom, do you feel like you have completely relieved yourself? Or do you feel like I've gone but I still have the urge to go more? Do I have a strong stream? So when the urine is being eliminated, is it a strong stream and can you control it? Can you stop and start again? Or is it a weak stream and you don't feel like you empty and then you wait a while and then you strain and you start to go again? Those are the types of questions we have to ask. And a lot of times people are going to be very uncomfortable answering those questions. Okay? And a lot of times we think, oh, well, how often do you go? Do you have any dribbling? That's kind of where they end it. How many times do you go? Do you have any burning? And a lot of times when people say, do you have any burning? What was I doing with my head? Do you have any burning?
People,
You're nodding to say no, say no. Okay, and the patient will pick up on that. Okay, so we have to be very well aware of what our body language is saying to that patient. Okay, your book has some nice questions. If I can find them. 1328. Okay, and this, rather than saying yes or no, okay, your book says to tell them, answer always, sometimes, or never. Okay, so it's not a yes or a no. It's not a clear yes or no. Do you ever leak urine or water when you don't want to? Do you ever leak urine or water when you cough, sneeze, laugh, or exercise? Do you ever leak urine or water on the way to the toilet? Do you ever use pads, tissues, or cloths in your underwear to catch urine? If an answer is always or sometimes, perform the focused assessment in the urinary continence box. Okay, so then you go to that urinary continence box and you'll see all of those questions for the focused assessment. Okay, but I think a lot of times we want an all or none, yes or no. Okay, and I think that sometimes is a huge way to capture, well, yes, sometimes it does happen. Okay? Then with the physical assessment, okay, we're going to assess the abdomen. Okay, and what does our full bladder sound like? Is it a sharp or dull sound? What's a full bladder sound like? Kind of a thud? Dull? Okay. Again, nurses, we won't necessarily do this, but we will assess physicians. Inspect females for prolapse. Okay. Unfortunately, we can have the internal organs prolapse and start to protrude out the vaginal cavities. Okay. So we have to be aware of that. Okay. The healthcare provider will also perform a comprehensive exam, and that includes DRE. DRE is a digital rectal exam. Okay, looking for protrusion, looking for any type of bulging, abnormality, anything there. Okay? So our lab assessment. Okay, urinalysis. What are we going to be looking for? What are we going to be looking for in a urinalysis? Something that's not supposed to be there that could be contributing to our incontinence. Okay, so infection. Okay, then our imaging. Okay, bladder scan, CT scans. Okay, the VCUG is a voiding. Okay, so they're going to do a scan. Okay, they're going to inject dye, watch how the bladder fills, and then actually scan while the patient is urinating so we can see, is everything functioning correctly? Okay, so that's a functional test. Okay, the urodynamic test. Okay, looking at the pressures, looking at, is everything functioning? And then the EMG of the pelvic muscles is looking at applying electrical stimuli to those pelvic muscles, making sure that they are contracting like they're supposed to. Okay, and that's very valuable information if I have some type of neurological disorder, I have some type of spine issue, low back pain, something like that. Okay? Altered cues. Okay? Altered urinary elimination due to incontinence is going to be one of my nursing diagnoses, or the potential for altered tissue integrity. Why would I have altered tissue integrity?
Like your skin's wet, being wet.
The skin's wet. Okay. Have you guys seen the pure Wit Catheters in the hospitals yet? Okay. So that's a method that it's applied to the vaginal area. Okay. It's kind of almost like a suction, like a wound vac. And it helps, a pressure is applied, suction pressure is applied to wick that urine away, okay, for patients who are incontinent. What are the other devices? What are some other devices for incontinence? Condom pad,
Foley.
loud,
Foley.
Foley. What else? There's advertisements on TV all the time. They look real now.
Diapers.
Yeah. Incontinent pads, incontinent underwear. Okay? So that I can function, I can go places, I can do things. Okay? But I have an incontinent device. Okay, so if you're looking at a chart and it says incontinent device, okay, you need to ask what type of device. Is it a pad? Is it a undergarment that they're wearing? Okay, because there's a difference between they wear a pad like the name, it's in a purple package, I can't think of what it's called. But a pad that they put in their pants versus an underwear. Okay, and that becomes important in can they change their device by themselves? Okay, so can I change my pad in and out by myself independently versus can I take my Depends, my underwear, undergarment on and off, or do I need to have help doing that? Okay? All right, let's stop for lunch. We'll pick back up at noon. My goal is to finish all of this chapter and get about halfway through 62.